I would say what I've been saying all along, that we have 60 million people in this country who are not vaccinated, who are eligible to be vaccinated. Let's get them vaccinated. Let's get the people who are vaccinated boosted. Let's get the children vaccinated. That's where we want to go. Is that even though the vaccine isn't specifically targeted to the Delta variant, when you get a high enough level of an immune response, you get spillover protection even against a variant that the vaccine wasn't specifically directed at. And that's the vaccine isn't specifically targeted to the Delta variant. The vaccine isn't specifically targeted to the Delta variant, a variant that the vaccine wasn't specifically directed at, a variant that the vaccine wasn't specifically directed at. First of all, the current seasonal influenza vaccines are not consistently effective, and that's a fact that we just have to face. If you look at from 2004 until the last year, when you have a bad year with a mismatch, as we saw in 2004-05, you have a 10% efficacy. At best, as we had in 2010-11, you have a 60% efficacy. Compare that to other infections that we have vaccines for. Measles vaccine is 98.5% effective. Yellow fever is 99% effective. Polio is more than 90% effective. Now, there are a lot of reasons for that. We all know about the drifts. We all know about the mutations. We all know about the fact that the response against the hemagglutinin, although it can be very effective, drifts from year to year and sometimes shifts. But this is the stark reality of how we address seasonal influenza. We all know about the mutations. We all know about the mutations. When you have a bad year with a mismatch, we all know about the mutations. A variant that the vaccine wasn't specifically directed at. A variant that the vaccine wasn't specifically directed at. Bad year with a mismatch, as we saw in 2004-05, you have a 10% efficacy. You have a 10% efficacy. You have a 10% efficacy. So in April, this is a picture of my good friend Ann Schuckert and I testifying before our Appropriations Committee in April, saying, and you could go back and see what we said, is that it's April. It takes about 6 months to get a vaccine going. So if we start working now, May, June, July, August, September, October. If we have the vaccine by October, then we'll be prepared for the inevitable pandemic. However, what happened? The children came back to school, and instead of having an epidemic or a pandemic that peaks in January and February, it peaked in September, as graphically shown on this slide. So what's wrong with this slide? The blue line is where the red line should be, and the red line is where the blue line should be. In other words, the percent of illnesses peaked before we had the vaccine available, which became available. It would have been wonderful if it had a peak in January, but it didn't. It peaked in September. So even though we have some warning about a pandemic, even then, with our current capabilities, it doesn't work well. This is a picture. Notice the expression on Tom Frieden and Jesse Goodman explaining to the House Oversight Committee about the vaccine that we were supposed to have in time. We didn't. And then there's the third thing, and that is chasing after potential pandemic outbreaks. I refer, and others refer to them as pre-pandemics. And that is chasing after potential pandemic outbreaks. And that is chasing after potential pandemic outbreaks. It is costly and it is ineffective. And let me just give you a couple of examples. You all recall the H5N1, the chicken virus that started in Hong Kong, jumped species, had a high degree of mortality, but didn't develop the capability of going efficiently from human to human. We took this very seriously. And what happened? It was during the George W. Bush administration. He asked for over $7 billion, and we spent about $4 or $5 billion to switch from eggs to cells, which I don't think is a very major advance, as we'll get to in a second. But we made a vaccine, we put it in the stockpile, and nothing happened. But we did do something really good. We put a pandemic influenza preparedness plan involving what you see on this slide. We approved the vaccine that we had. The first adjuvanted H5N1 is available, stockpile. We didn't use it. Then what happened is several years later, we had the H7N9, same thing. Chicken virus jumps from chicken to humans, high degree of mortality, not efficient from human to human. It started in 2013. We were quick. We made a vaccine in 2013. We stockpiled it. There was a mini outbreak in China in 14, 15, 16, and then what happened in 17? It mutated a little, and the virus and the vaccine that we had for the 2013 strain was not protected by the vaccine that we developed for 2017. So we had to go back again and start all over.
What did you say?
It mutated a little, and the virus and the vaccine that we had for the 2013 strain was not protected by the vaccine that we developed for 2017. It mutated a little. The current seasonal influenza vaccines are not consistently effective, and that's a fact that we just have to face. It mutated a little.